The topic that we will be discussing today, the degenerative cervical spine. As you can see, the topic is very big, and we will try to touch base the most important part of the cervical degenerative spine. So we know that this kind of pathology is very common, and we get to see a lot of cases similar to what you see in front of you. This is a degenerative cervical spine. You can see the advanced degeneration that's involved multiple parts in the spine. Or it could be even less extensive in involving a single level as we see here. So there's a variety of different pathology that can involve the cervical spine. So the commonest is what we call it cervical spondylosis. That's a common pathology, and it is a natural degenerative process that as we age, as we grow, as early as even early 30s of age, we still are liable to get some degeneration starting with the disc. So the commonest is to get what we call it an axial neck pain due to the disc problem, or radiculopathy when the nerve root is involved, and when the spinal cord is involved, then it's a myelopathy. So it's quite common between the age of 40 to 50, and 85% of affected patients are above the 65 of age. So that is common with aging. So the more the patient is older, the higher the risk of developing the degenerative cervical spine. And it's more common in men than women. And the location is commonly at the lower cervical spine, C5-6 and C6-7, and that is related to the flexion extension movement of the subaxial spine. So cervical radiculopathy is a very common problem, and it usually follows a dermatomal distribution in the spine and defined as a presence of motor or sensory deficits that go along, extend along the nerve root of the level of involvement. The causes is due to the spondylosis, which is reduction in the disc height, bulging of the disc, some narrowing of the foramen, then that will cause an entrapment of the nerve root as the nerve is moving out of the canal in the foramen. So also can be involved in a soft disc herniation or stenosis due to the facet hypertrophy or instability due to the occult movement in the spine, then stretching the nerve root in the foramen. And the same thing with the spondylolisthesis or retrolisthesis. It could be to the front, that's called spondylolisthesis, or it could be to the back, when it's called retrolisthesis. So, as we've said, it's common in male than female, and the age peaked at about 50 years of age. And the nerve root, usually it can affect any nerve root at the lower cervical spine. 6 and 7 is the commonest. So the anatomy, the cervical radiculopathy is a common secondary changes that will develop with the mechanical compression due to the nerve root. And the subaxial cervical spine has 5 articulations. Think of it: the disc at the front, ancovertebral joints, 2 of them on the side, and then the facet at the back, both sides. So that's the 5 articulation. Whatever the pathology is, it can affect nerve root. And the if you think of the cervical spondylosis, it's by itself, when it's advanced, it can cause a disabling condition. And the consequence of aging and the vast majority of affected population will let the patient be more symptomatic as they grow. And the neurological symptoms in the cervical spine are a result of a cascade of degenerative changes and usually start at the disc level. So in the beginning, dehydration of the disc, and then the disc lose its integrity and the strength, and then some settling, bulging of the disc components, and then the process ongoing will start by affecting the nerve root in the foramen and then causing the radiculopathy. So think of this diagram. So this is the disc front, this is the posterior element, and that's the facet, and this is the ligamentum flavum with the lamina overlying it, and the spinal cord at the back and the foramen with the nerve root is causing out. So if the disc material compresses the nerve root, then that's causing a front offending structure. Sometimes with the ongoing long process, some fights formed, could be at the front, could be at the back, and then the same thing will compress the nerve root. Or it could be from the that narrowing from the uncovertebral joints cause the same thing. And the facet joints, as if it also hypertrophied with the hypertrophy of the facet, can also cause a compression on the nerve root. So the pathophysiology is all related to the age condition, and with the changes in the disc material and the progression of the changes affect the viscoelastic condition. صوتي واضح يا شباب ولا انقطع؟
واضح يا دكتور، تفضل.
واضح.
في اصوات طلعت جديده، يعني هذه ايكو من عندي.
احمد
يمكن احد شغل المايك من عنده. انت عامل كنترول على المايكس مضبوط؟
ايوه ان شاء الله.
Good. So if the disc material is soft, can compress the nerve root. If it's becoming ossified, and then an osteophytes formed that can also compress the nerve root, and all will lead to the what we call it cervical radiculopathy. The ongoing compression on the nerve root will create a sort of inflammatory changes with the mechanical compression, and if the movement is there with the instability, that can cause more inflammatory changes and lead to an inflammatory mediators around the nerve root, and then lead to the pain. So with the compression of the nerve root and the intrinsic blood supply to the nerve root of interest, some cause permeability changes, and secondary results in edema and nerve root swelling. That can cause to ongoing chronic changes around the nerve root, and edema and fibrosis, and then affect the nerve root. Affected nerve root will respond to will be more altered to the thresholds of sensitivity to the nerve pain, and that can lead to the radicular pain of a chronic origin. So all of that is the pathogenesis of how we get the cervical radiculopathy and the radicular pain that propagate along the nerve root. The neurogenic chemical mediators of the pain released more from the cell body and the sensory neurons, and non-neurogenic mediators as well, all released from the disc tissue, can reach to the chronic inflammatory changes and the pain. So all of that is related to the pathogenesis. How do we get a pain that is propagated along the nerve root from the cervical radiculopathy? So what does it mean when we have a cervical radiculopathy? What's the impact on the patient in the future? That's what natural history will tell us. So it's estimated that slightly more than half of the adult population will have a sort of a similar presentation, at least during their late time in their life. And it was well described in the literature, and it's been confirmed that 30% of the people experiencing intermittent radicular symptoms, and 25 has a persistent pain. And 23% will have a persistent neck or radicular pain, were unable to return to their normal work again, and that will lead to unemployment in about a quarter of the patients. So that is the natural history of the disease. And then if we look at how to evaluate the patient, we will look at their clinical history. Usually the patient will present with the pain, paresthesia, and weakness. And specifically, looking at the specific nerve root, C3 radiculopathy, it doesn't have a motor part, so it will give a sensory distribution along the back of the head, and then usually the occipital headache will be related to that nerve root. If we think of the C4 nerve root, the same thing. It will affect the pain that will propagate along the back, and commonly it goes between the shoulder blades as well. So the patient will tell you, I have a pain that goes from the neck and then goes down along the trapezius itself. The C5 nerve root, it goes along the distribution of the shoulder, and the motor part will be the deltoid. We'll discuss that more in details with the examination. The C6 nerve root, it follows the distribution of the C6 as you imagine it in the anatomical distribution, the dermatome distribution of that nerve root, and goes along the lateral aspect of the forearm and dorsal aspect of the hand. The brachioradialis, when you examine that, will be depressed on a reflex, and the rest extension will be the one, especially if you're doing like a hammering effect. The C7 nerve root goes along the back of the arm, which is the triceps, and will be affected when you test the reflex of the triceps will be depressed due to the compression of the nerve root. C8 is least likely to be pain, and commonly it has some sensory changes around the wrist, and the weakness will be in the hand movement and the grip. So whenever you have a cervical radiculopathy, think of differential. It could be an entrapment outlet syndrome, entrapment, peripheral nerves, and even any tumors that can compress nerve root at any level distal to the spinal canal can also present with the same situation. So evaluation, simply start with the plain x-rays, which are going to show you a degenerative changes around suspected area, and MRI will show more details of the neural condition and the soft compression on the specific nerve root. And if there is some ongoing bony components like an osteophytes formation or OPLL, ossification of posterior longitudinal ligament, that's going to be shown clearly through the CT scan because it's going to be showing more of a bony component. EMG sometimes very helpful in evaluating patients with the occult cervical radiculopathy that is not very clear on clinical evaluation. It can pick patients will support the diagnosis clearly. Is it so clear so far, Shabab?
واضح دكتور ممتاز.
تمام الله يعطيكم العافيه دكتور.
Management. Now, the management, when we're talking about cervical radiculopathy, then there's a very good room for non-operative treatment, starting with the brief time of cervical immobilization of the cervical column. It will give a sort of a relief to the nerve root, short period of immobilization will lessen the inflammatory changes around the nerve root, and that the pain will respond well to that time. Home traction has been proposed. It can be done, even some specific color can have that maneuver. It's a pumping effect. It can provide that. There's a variety of different devices can be used for that. There's some studies supporting the use of with some good benefit. And pharmacological management would support some muscle relaxant, short time use of narcotics, non-steroidals, even oral steroids might work at some specific cases. And the use of epidural steroid or even nerve root infiltration can give some improvement as a sort of pain management. Physical therapy is needed in order to put the patient back on track and then get back to function. Traction can be done with as a sort of physical maneuver, physical therapy maneuver, and there is a good evidence about the improvement. But that is might be a good alternative for usage in only cervical radiculopathy. And it has been shown that this gives a very good relief to the patient when it's done under the trained hands. Cervical radiculopathy, when should we elect to go for surgical management? This is an important slide. A patient who have a persistent and recurrent radicular manifestation and unresponding to conservative management for a minimum of 6 weeks can be a patient who is a candidate for treatment, surgical management. Disabling weakness progressive for 6 weeks and more is an indication. Progressive neurological deficits, static neurological deficits combined with radicular manifestation. Sometimes the arm pain is really disabling. Some of those patients cannot even get to sleep. They're awake all night and they consume a lot of medication in order to get to sleep. That is a very important indication for surgical management. And when there is an ongoing symptoms with an instability or even deformity, then that's a clear indication to go for surgical management. Now, the other side of cervical advanced cervical spondylosis is when the compression starts to be more in the center, and then that will give you what we call it myelopathy. Myelopathy is a more serious disease than radiculopathy because simply here we're handling central neurons. So that is an upper motor neurons. The bad thing about it, if you get a defected upper motor neuron tissue related part, it's hard to get it recovered again. So that's why when we have our upper motor neurons, we need to pay more attention to such a patient who will be presented with a myelopathy. So what does the natural history study tells us? It tells us like 75% of those patients will have stable neurological functions. They will not have a clear deterioration apart from streaks. And 20% will show a slow, steady progression without a stable period. So they will have clear progression. And 5 will have very quick deterioration. And that's where we need to be really careful when we handle patients with such a condition, because they will be crippled within a short period of time. And usually, if you look at the pathological conditions, it's similar to the radiculopathy, it's age-related. And when there is an instability, kyphosis, or posterior longitudinal ligament calcification, and some of those patients may have predisposed canal by having a congenital stenosis. So they were born with a congenital stenosis. So they have less chance to get through some degeneration compared to normal people when they don't have congenital stenosis. So minimal degenerative changes that will be tolerated well with some normal people will not be able to tolerate that when they have a congenital stenosis. They will develop symptoms much faster, and this is classically in a younger population. So the pathophysiology, looking at the pathoanatomical changes have a direct compression on the neural tissue and result in cord ischemia. Mild to moderate compression associated with degeneration of the lateral white matter. A more severe compression will affect the gray matter itself and some central necrosis. The axonal demyelination followed by cell necrosis and gliosis will result in scarring if this patient has been there for a long period of time. And cystic cavitation can occur within the gray matter. Chemical and cellular mediator also will be involved, and then some of these patients will present with myelopathy as well as radiculopathy. So it has to be also defined clinically. This patient will present with pain. The paresthesia that is presented usually here is non-dermatomal. It will be a global eruptions, and then the upper extremity usually will be affected. Weakness will be also very common, but a bit late in the progression. And gait and balance will be affected as the disease became more significant. So clinically, when you look at the sensory symptoms, spinothalamic tract, when it's affected, it usually cause a pain and temperature contralateral side affected, with the light touch being preserved. And the posterior column, when it's affected, it starts taking the ability to have the position sense, and then that's when the gait is affected. The dorsal root, when it's affected, it gives the dermatomal distribution, and that will be more of a radiculopathy component than myelopathy. And the motor part, when the level affected is significantly deteriorate, it will give typically a lower motor neuron, and this is something to explain. If the compression is at C5, 6, and that level is affected, then the nerve root is already out of the central part of the spinal cord. So it will be more of a lower motor neuron. So it follows the situation of a nerve root involvement rather than upper motor neuron. So that's why it will have a lower motor neuron effect with the hyporeflexia of that specific nerve root. But the level below, it will be affecting the central part of the cord, and then the patient will show you the levels lower than that, including even the lower limb, upper motor neurons. And that is why you can have a mixture of upper and lower motor neuron signs in a patient, in some patient with the myelopathy. The upper motor neuron signs below the lesion will be showing a full-blown pictures of the hyperreflexia, clonus, spasticity, all the regular signs of the upper motor neurons. Quick review. You will be looking at a motor, sensory, and reflexes. If you remember the age scoring, you will just follow the same thing. Some difference between textbook that is varies commonly between the C5 and C6 nerve root. Because of the common double innervations, you can see some bit variation of the supply, explanation. So Going as C5, there's an agreement about the deltoid and the biceps, and as a motor evaluation, some text explaining C6 to be the biceps as well, so don't be offended by seeing that. How come it's there? Yes, because it's a double innervation, but always keep it in mind, C5 and 6 will be also involved in the biceps. The dermatomal distribution, remember the same pictures that you have it in your mind from the AJA scoring, you just follow that, the same thing. The biceps, when you do the reflex, it's commonly taken for the C5 nerve root as a sort of a reflex. The C6 is commonly with the brachioradialis. The C7 is the triceps. The C7 extensions of the finger is also triceps. So I don't want you to be confused. If you stick to the AJA scoring, that will be fine. Plus, looking for the pathological cord reflexes, which is Hoffman's sign, inverted radial reflex, and the finger escape sign. Remember these signs, as well as squeeze release reflex, squeeze release hand checking to see the coordinations and the smooth movements of the hand within 20 compression release in 10 seconds. That is a normal finding. And then look at the long tract effect in the lower limb with the Babinski sign, the plantar reflex. If it's positive, then that's the related to the upper motor neurons, and the clonus. When there is a severe compression, the gait will be affected. Numbness will be distributed among the upper extremity. Fine motor will be affected. Dropping hands, hand functions will be affected. The sphincter control is usually late when the myelopathy is the presentation. A sort of classification. When the patient presented in the first stage, the patient will have only a root sign. There's a normal cord functions. And when the signs of cord involvement is there, then that's stage 1 and normal gait at that time. And if the mild gait involvement is there, that's stage 2, but is still able to be employed. And it's not surprising to see some of the staff. I do see some of the staff, they have a myelopathy and they're still up on their feet. They're still working, and in spite of having a myelopathy. And that is because of this, they are still at the early stage. When the gait abnormality become more of a problem and start affecting their ability to work, and that's a stage 3, and that's a good time to intervene. And when some patients, as we see in the clinic, are reluctant to be operated at that stage in spite of having a progression, then they will have some problem with their ability to ambulate, and then they will be starting to use some help of a cane, and some of them walker as well. And sometimes they even be reluctant to be operated, and they get to you when they have already inability to walk and they're wheelchair bound, and they tell you now, we're ready for your surgery. Unfortunately, they're late at that time, but it's still indicated. You cannot say no for them when they are at that stage. Differential diagnosis, I want you to remember about the other possible causes. The medical causes for the myelopathy is a long list, as you see in this slide. So think of a possible causes from the medical side. The commonest is a motor neuron disease, multiple sclerosis, cerebrovascular disease can also come with the myelopathy, sometimes accord problems. So think of all of that as a sort of non-compressive myelopathy. That's the big title. And then if that is the case, send them to your colleague in the neurology. So that's not your case, it's a neurology case. Non-operative management usually comes in the context of observation, close observation, to see if the patient has signs and symptoms of myelopathy that is progressive. So you need to keep an eye on them within usually 6 to 12 months time, regular visits. And if the patient are in a plateau, then you just give them a supportive treatment. And if they're early stage, and if the patient is stable, no neurological deterioration, that might be a time to observe. But if the patient has a progressive symptoms, that's your clear indication, and that is the only clear indication to operate in a patient with a myelopathy. So we say cervical myelopathy is a surgical disease when you have a clear cut symptoms and sign with a documented progression. That is what you're going to say is the surgical cases. The presence of myelopathy for more than 6 months time without any improvement and further deterioration. And when the dimension in the MRI, you could see that the canal is narrowed and the cross-sectional area is within the 40 millimeters square. So that is a compression of the cord itself rather than this the dura. So when you see the cross-sectional area of the cord is compressed, so that's a radiological signs of surgical indication. The goal of operative intervention, simply we want to alter the neural progression of the disease and prevent further deterioration by decompressing the spinal cord, provide stabilization if it's not there, and then reconstruction of the spinal column in order to have a safe neural condition that involve segments. Surgical approaches, you could go anterior, you could go posterior. There's a different way to achieve things. So when you go from the front, you could go with the simple disc, what we call it ACDF, anterior cervical discectomy and fusion. Or you could take the vertebral body, and that's called corpectomy, and all of that can be done from the front. It can be done in a single or multiple level, up to 3 levels. Or you go from the back, whether to go selectively for a specific foramen, if you have a radiculopathy, what we call it foraminotomy, or you could go multiple level, sometimes laminectomy by itself in a specific condition can be done, and we'll talk about that. Or you could do a laminectomy with an instrumentation, and that is the commonest approach when you go from the back, and we'll talk about that as well. Or you could just go for what we call it laminoplasty by doing the lamina maneuver to achieve decompression without causing fusion. We'll talk about that. So we are up to the anterior procedure. If we go from the front, what we call it the ACDF, we can do this procedure from C3 to T1. And classically, we do that to achieve a direct decompression from the front of the affected side. We do that up to maximum 3 level. We don't take more than 3 level because of the increased risk of offending the structure nearby. The important vital structures will be affected as you have more than 3 levels, because you will be compressing them more and manipulate them more, and that will be difficult to the patient to tolerate for a longer procedure, as you need to extend more than 3 levels. For that reason, we don't dare take it more than 3 levels. Left side is being proposed because of the stable course of the recurrent laryngeal nerve, and that was an old study, and the recent studies are supportive for right and left side, as long as you know where is the nerve root and then protect it, then you will not be facing that issue. And that is classically for right-handed side, like me, I do always go to the spine from the right side, because it depends on the surgeon preference, but you need to pay attention to the recurrent laryngeal nerve. The approach, simply, you will be taking from the transverse skin incision. You will go through the platysma, superficial fascia, the platysma, and then you will take the deep cervical fascia, identify the sternocleidomastoid, and then open the fascia. You go through the loose areolar tissue. You shouldn't see any muscle fibers. This plane is usually avascular and you won't get a bleeding. You will be going through the pre-tracheal fascia with the carotid sheath on the lateral side underneath your sternocleidomastoid, and then you take the strap muscle with the tracheoesophageal tract medially. And then by doing that, you will be facing the pre-vertebral fascia, and then you will see you have to identify the midline with the colli muscles on the sides, and then open the pre-vertebral fascia and then stick to that side. Now, if you are out of plane, you can find some trouble. Starting with the superficial plane with the carotid sheath, you have to be careful identifying the carotid sheath at that level on the lateral side. On the medial side, you need to be careful about the tracheoesophageal tract, because if you're out of plane, you can be fiddling with that, and then patient will develop a significant problem of the tracheoesophageal tract. You can have edema of the wall of the trachea, and even the esophagus can have a perforation as well, especially if there's nasopharyngeal tube on the side. Remember, the also nasogastric tube can be also easy to perforate if you're operating around the esophagus. So you have to be careful about the plane, to be out of plane. The longest colli is important. If you go on top of the colli, you will find the sympathetic tracts. Then you will be putting your patient at risk for developing the Horner syndrome post-operatively. So always you need to be on the midline and putting your blade on the anterior edge of the colli in order to be at the right level. Spanning levels up to 3 levels is enough. More than that, you will put more stretch on the tracheoesophageal tract, and patient will develop edema, and then will be hard to extubate post-operatively. And some of those patients will even decompensate in the following days. And all of that, I'm explaining it to you now in order to understand why we're not going more than the 3 levels. And if you are at the right side, usually these procedures are bloodless. So you will accomplish this procedure with the maximum blood loss of not more than 10 to 30 cc of blood loss. So you're not even getting to 50 cc of blood loss. Bone grafting, we don't do that. Usually we use cages for anterior disc fusion. You put the cage plus some autogenous bone grafting you harvest during the decompression procedure. But if you're doing it for a trauma, then we do what we call the tricortical bone grafting. We take it from the iliac crest. And that can be an option if you're revising a failed fusion, which is hardly ever you face if you're doing the procedure the proper way, where you need to do a proper decompression, squaring your end plate, and then harvesting autogenous bone grafting, putting the cage at the proper side, and then putting the plate with it, or even cage screws, where you put the screws through the cage itself in order to stabilize it. After you achieve a good decompression all the way to the back, where you see the posterior longitudinal ligament, and then you open it if you have a myelopathy. If you have a radiculopathy, maybe you don't need to open the posterior longitudinal ligaments. So all of that is at technical points. I'm explaining it so you could understand what are you targeting when you go through this procedure. Old Cloward technique, just if you face it when you read the text and sometimes in the MCQs, this is what they call it, the Cloward. It was circular piece that was taken from the iliac crest, oversized, and then squeezed in the end plate in order to be locked without even plating. That was done in the past, but it's an obsolete. Nowadays, we don't do that anymore. So most of the time, if you're doing it, you will doing it like the Robertson Henshaw grafting, where you take a tricortical and you put it in. And classically, we do that when we have a trauma case in order to have a faster fusion. So the advantage of that is to have a faster fusion in order to put this patient back to full function as quick as possible. Complication of the anterior approach, we've said recurrent laryngeal nerve palsy, thoracic duct injury. That's a disadvantage when you go from the left side. You will be facing a thoracic duct, and usually at the lower part of the exposure, if you're approaching the C7, T1, thoracic duct will be liable to be injured on the left side. So not all the time left side is great, let me go left side. No, left side, if you go there, and especially lower cervical spine, be careful about thoracic duct. It might be injured. I've seen it once during my training, so that is a chance to be injured. And if you get that, you need to call your colleague and the thoracic team to help you with that. Esophageal injury, yes, it can develop if you're out of plane, so you have to be careful when you do your dissection, not to be out of the plane I described. Sympathetic chain, as I explained to you, Horner syndrome will be clearly presenting in those patients if you're working and putting your blade on top of the colli muscle. Failed fusion, you don't do a proper job, you don't do squaring, you don't harvest bone graft, you don't put proper stabilization, then higher chance of pseudoarthrosis. If you do things right, the chance of getting pseudoarthrosis is very slim, but it's still there always as a sort of a complication. Now we shift the approach for the back by doing what we call a posterior framinotomy. So if you have a specific nerve root involvement and you don't want to do a fusion, all what you want is just to help that patient to get rid of the radiculopathy, then framinotomy is a good alternative. So you could do that with an open approach through the back with the use of a microscope, see the foramen, and then you drill the foramen taking the roof of the nerve root, and then you will see direct nerve root decompression. and that will help the patient getting through his symptoms. So looking at this, you go from the back with the drill. This is the nerve root that is moving out. So by taking the roof of that nerve root, the patient nerve root will be decompressed and leaving the facets intact. You can go up to 1/3 of the facet without causing a problem. Then this patient will be able to have a normal range of motion. It's a fusion-less procedure. And such a patient can be done as a one-day procedure or even as an outpatient if you do a decompression of a specific nerve root. This can be done also minimally invasive. You drop the tube and then under the microscope or even endoscope, you could do the same procedure under the help of the X-ray because you will not be able to see things clearly when you duck your tube. So you need a lot of fluoro to be sure that you're putting the tube at the proper size. Downside of this procedure, you can be out of track anytime. You will be injuring the nerve root, dura, central part. You can have the injury to the cord itself if you are too aggressive. The epidural bleeds can sometimes be nasty at that side, so you have to be careful about doing it. And if that epidural bleed was not controlled, then it is not surprising to see a hematoma post-op, and that might take things into totally different dimension of a complication of such a patient. So this patient has to be observed clearly, and you shouldn't get out while the patient is bleeding heavily from the side, because you're going to be happy about the wound not showing any bleeding, but actually the hematoma is deep, and that will expand on the side, and patient will develop a cord compression, and condition will not be something nice to see. So we have to be careful and meticulous in controlling bleeding around that side. So all of this might be a complication. Plus, if you're too aggressive in taking the facet, and that might lead to instability, and patient will develop a long-term complication of occult instability, and such a situation has to be managed with the fusion as a follow-up procedure. Now, comparison, anterior and posterior. Posterior, we said it's an advantage. It's not a fusion procedure if you're doing from anatomy only. Compared to the anterior, you will be causing a fusion, so you're losing motion at that level, putting risk of the adjacent level. That is also a downside of anterior procedure. It eliminates complication of the anterior procedure when you're going from the back, but again, it has its own complication as just described. And you don't need immobilization if you're doing just a fromenectomy, but from the front, you will be, it's usually tolerated, but you need to immobilize the neck for at least 2 weeks because of the approach is a bit painful in the immediate post-operative. So 2 weeks of immobilization usually is good enough if you have a stable instrumentation with the plate or screws. So if you have a good stabilized situation, then 2 weeks is good enough for immobilization. The anterior has an advantage because you will be directly taking the offending structure. It's a disc compressing the front, so you're taking the disc, restoring the height, achieving a fusion. You have a better contact for a fusion from the front. You're preventing any further recurrence at the same side compared to the only fromenectomy, because motion is still there, some arthritis in the facet that might put the patient more at risk for developing an instability or even an axial neck pain. Patient will also complain of a recurrent symptoms due to that progressive condition, and then patient will be more at risk for a revision procedure. So everything has its pros and cons. Again, if you look at the recommendation of the American Academy, they looked at the patient who has is young, can be athletic, trying not to be fused, then it can be achieved through the frontenotomy procedure, only the back. And smokers also rest for non-fusion, so you could go away from the ACDF by just doing a frontenotomy. If patient has a hard disc herniation, facet hypertrophy, then an anterior procedure in order to decompress everything from the front will be a procedure to be done. Bilateral symptoms also can be achieved by going from the front. Advantage, the anterior approach, we've talked about the advantage of having a direct decompression, stabilization and fusion. You can correct the settling and the kyphosis that develop by restoring the height, so you're correcting the deformity. The axial lengthening of the column will be there by reconstructing the alignment. And the axial neck pain usually improve if it's related to that level. The posterior approach is when you have frontenotomy only, you said the motion is still there and technically demanding, not technically demanding, sorry. And as far as you're comfortable with it, in the beginning, in the early stage, it is difficult. But as you are more comfortable with the posterior approach, it's not technically demanding because you will be there in a short time and you start drilling the roof of the facet, roof of the nerve root. And you don't need to go through the hassle of the fusion and the failure of fusion. Disadvantage, we've talked about it as well. So instrumentation is added whenever you want to achieve fusion. Usually from the back, if you're doing multiple level decompression, usually with the lateral mass screws has the advantage of achieving a fusion and prevent loss of fixation on the bone graft as well as improve the post-operative rehabilitation and avoid the requirement for any prolonged immobilization. So when you put the patient prone, you have to be careful about starting with the intubation. Those patients with the myelopathy, it has to be done with a fiber optic intubation. And then the maneuvers has to be avoided. Most likely the anesthesia will be able to do. I remember the first case I did, the patient was intubated in a bad condition with the jaw thrust and chin left. And when I came in looking at the patient was looking up and bad in that position. I had to wake up that patient in order to proceed with the procedure because he had a very severe multiple level compression. So you have to be careful, discuss it with your anesthetist before the procedure. This patient has to be fiber optic intubation in order to avoid the extension of the neck. The mean arterial pressure has to be maintained around the 80s. Less than 60, less than 70s is not something advisable in this patient because they can have some sort of vascular incidents in this compressed side, and the patient will wake up paralyzed despite having an excellent procedure that you do. So having a good perfusion around the cord by having a mean blood pressure around the 80s, 70 to 80s is reasonable in order to have the perfusion maintained. So when you go from the back, the indication is to go there when there's a congenital stenosis that's spanning multiple levels, more than the 3 levels. If you have OPLL, it's not something nice to operate in the OPLL from the front because you will be drilling through the bone. By finishing those drilling through the OPLL, you will find the cord in front of you because the dura is very thin, that's adherent to the bone, and then you will be facing a difficult time handling the dural leak from the front at the time of continuous leak. In order to patch the dura in the interbody spaces, it's not possible to. So such a patient usually, it's advisable to go from the back by achieving multiple levels of decompression with posterior spinal cord compression from multiple offending levels, even diffuse idiopathic skeletal hyperostosis is also an indication which is similar to OPLL. This patient, when done, you have to be careful about the epidural bleeds. You have to control them in order to avoid the bleeds. I remember one patient who bled from just a simple decompression like this. So they bled 2 liters in just less than a 5-minute stat. By just getting through one of those epidural bleeds, it looked simple, but when it started, it's hard to control them. So it has to be, you have to look for them and then coagulate at the time of the decompression of the lamina. So multiple laminectomy can be done in a specific condition when you have an OPLL or even DISH, so the spine is stiff. This patient, usually they won't go anywhere, they're already stiff. So this is a classical procedure done by the anesthesia, simple laminectomy. It's unacceptable for such a patient. But if you do it for spondylosis and multiple disc degenerations and degenerative spondylosis, that is not something nice because they might develop a post-laminectomy kyphosis and segmental instability and deterioration of the improvement that you get following the laminectomy. Such a patient, they will have a good improvement post-operatively, but on follow-up, they will develop this kyphosis, and all of that because it was done in improper patient selection. And then this patient will be much difficult to handle. You have to go back and then approach things from the front, reconstruct the column, and then stabilize it with the plate. Classically, those patients, if you have to do them from the back, you add the instrumentation with what we call it lateral mass screws, and achieve fusion by drilling the fasces and putting bone grafting as well in order to get a fusion. A complication of going from the back with the instrumentation, nothing also bright without complications. Everything has its own pros and cons. So if you go from the back, in the cases of the OPLL or even DISH, spanning multiple levels, it's higher risk of infection that goes up to 10% compared to the front, which goes up to 2% compared with the back. You will be handling direct neural tissue, so you can have an instrumentation from the drilling or from the screws when it's going through the pyramid. The hematoma can develop, and then it will be catastrophic complication if you don't observe your patient closely, especially in the first 24 hours. C-step leak can develop, screws can be pulled out because these are not the big screws, it's just a tiny screw. So the technique for lateral mass screws is crucial because you have only one shot. If you don't do it right, you will blow things up. So if it blow out, then you get no chance to put any screws again at the same level. The other procedure that is non-fusion procedure is called laminoplasty. With the laminoplasty, you do think of that procedure when you have a spanning ossification along the posterior longitudinal ligaments, the OPLL, or even dish. You don't want to go from the front, but you want to achieve decompression from the back. It can be done also for multiple spondylosis, when you have stenosis that is more than the 3 levels, and even in a congenital stenosis, or even degenerative stenosis at multiple levels. The techniques for that, there's 2 techniques called, one of them called open door laminoplasty, is being described by Hirabayashi. That's the technique where you cut the lamina on one side completely and you weaken it on the other side, leaving only one cortex, and then you open it like a hinge door. And then you keep it open by the specific material. We'll talk about it in the following slide. The other technique called French door. So you weaken the lamina on both sides, only unicortical, and then you split the spinous process in the middle, and you put something in the middle to keep the door open. That's called French door technique. So that can be stabilized with the plate, suture, or even a bone graft. So you can put whatever you think is, it works for you. Classically, the plate will be the ideal, and that's my personal preference. So this is the plate that you could use for the fingers. So we're using it as fixation, mini fragment screws in the fingers. It can be used the same thing in the lamina. So I cut the lamina on one side, and then weakened on this side, and then you jack it open, and this is the spinal cord. You can see it clearly. And then the space you get here is huge when you just elevate the lamina and you fix it. And this is not a fusion procedure. You put the patient in cervical collar for only 4 to 6 weeks to let this area heal, and then you take it off, and then the patient will be able to move the neck. The combined anterior and posterior procedure that can sometimes be in need. So you achieve things from the front, and then classically, if you go more than 3 levels, and usually you spare it another day, because you don't want the patient to go through this big procedure, because most of these patients are elderly and they cannot tolerate big procedure of a full OR day like the young people. So you do the front procedure, and then you can bring the patient in the following week when he's recovered from the anesthesia, and then you do that back procedure. So in conclusion, I want you to think of the anterior cervical discectomy and fusion. And there is a myelopathic for 1 up to 3 level from the front, the anterior plate. You can combine it with a corpectomy and a strut grafting when there's a myelopathy with osteophytes formation retrovertebral. Think of it always retrodiscal or retrovertebral offending structure. If it's behind the vertebral body, you have no way to reach other than taking the vertebral body. If it's at the higher up, you can do a partial corpectomy. But if it's at the mid part of the body, you have to take the body, so that's a corpectomy, and then you replace it with the vertebral body. Replacement with the strut bone grafting, or even a destructible cage. The back can be done with just a laminectomy when the cord is compressed more than the 3 level, maintained, but laminectomy only if there's a patient has a normal lordosis, has ankylosed stiff spine like the dish or OPLL, absence of significant neck pain, because if you leave patient without motion and he has a disabling neck pain, then non-fusion procedure will cause that patient to move more post-operatively, and his neck pain will be more, and the patient will hate the intervention that you did, and he will hate you because he will have more disabling neck pain. and then he will go to somebody else to fix his problem. And then laminoplasty is an indication when you have an OPLL, multiple levels, and congenital stenosis, and the patient has no significant neck pain, and his lordosis is maintained. So these are the quick indications to go for. So in conclusion, degenerative process of cervical spine is a common in elderly, and it's a progressive disease. So you need to keep an eye on patients who has symptoms, and when the patients start developing symptoms of myelopathy, then that is your close observation and indication to go for surgical intervention if it's documented. And when symptoms do arise, clinical syndromes are best grouped into axial neck pain, radiculopathy, or myelopathy. So when you have degenerative cervical spine, just think of them this way. Am I dealing with an axial neck pain only, cervical radiculopathy only, myelopathy only, or combined two of these or all of them? So based on this evaluation, you can make your decision which way to go and what is needed to be done. And the natural history suggests that the best treatment in general for patients with axial symptoms is to go non-surgical. So axial neck pain, try not to operate on them, support them with non-surgical management. And patients with radiculopathy who continue to experience disabling neck pain, and those will be a candidate for surgical intervention. Arm pain is a clear indication for surgical intervention, and surgical decompression and stabilization could be considered. Patients continue to have the symptoms who failed treatment for a minimum of 6 weeks, and patient who has a clear symptoms of and signs of myelopathy is clear indication for surgical intervention. We're done with the big heavy topic. الشيخ طريقة الله يسامحكم. Opening discussion now for questions. انتوا غشيتوني اليوم ترى على فكرة، حطيتوا لي المحاضرة كلها اديها انا، لكن كنا نبغاها انتراكشن بس ما تجي السيتويشن هذه.
الله يعطيك العافية دكتور وما قصرت، شكرا جزيلا. الشباب إذا في أي سؤال تفضلوا.
Hope it's clear. No, I'm just kidding. أنا أتوقع فإنه هاي الطريقة هي الأنسب. المفروض إنه تتعامل كلها على شكل محاضرات. أعتقد الانتراكتيف سيشن is not possible مع الطريقة اللي احنا فيها الآن بالزوم، بالذات لما يكون توبيك كبير زي كده ونحتاج نغطيه كله. Brief specific topic, we can make it as a discussion. Big topics, I think your way of designing it with a lecture, I think is the ideal. لكن مع الأسف لما تكون big topics زي كده, you need more time and heavy. إن شاء الله المجموعة كلها صاحية وسمعت، أعتقد في مجموعة أكيد نامت.
الله يعطيكم العافية دكتور.
الله يعافيكم. طيب أنا أعتقد إنه حتى موضوع الأسئلة يمكن صعب الآن لأنه المجموعة كبيرة ويمكن ما حد يحب إنه يسأل. يمكن موضوع الشات لو شغلتوه كان معقول. هل الشات شغال؟
ايوه شغال الشات، شغال الشات.
انت مودريتور من عندك، جالك اي سؤال على الشات؟
ايوه في طلال يسأل would it be possible to get the lecture. طيب هذه بعدين نشوف نرتبها ان شاء الله مع الهيئة.
في اي سؤال عن التوبيك؟
Yes, hello doctor, how are you?
Fine, thank you. تفضل، مين معي؟
Yeah, أنس معك R5.
هلا يا أنس، تفضل.
Doctor, one of the indication of surgical management of degenerative cervical spondylosis is persistent of symptoms despite non-operative measures. I don't know what is the ideal duration of time. Is it 6 weeks or 3 months? Because I mean, like in the
sorry, Anas, are you talking about radiculopathy or myelopathy?
Radiculopathy.
Cervical radiculopathy, it has a very good prognosis. If you look at the patient who has a cervical radiculopathy, tell me, what do you guess? A patient who has a symptoms and sign of a cervical radiculopathy and you treat them conservatively, what is the chance of improvement in 3 months' time? Percentage?
Well, I mean, I think more than 50%.
90% actually. So they have a very good chance of improvement. So cervical radiculopathy, you don't really need to go for a quicker intervention. So a minimum of 6 weeks. I do sometimes extend it up to 12 weeks. So I have a very good room for observation and supporting patients with the cervical radiculopathy. Unless they have a devastating symptoms and progressive, then that's a clear indication for cervical intervention. Arm pain that's interfering with the patient situation of daily living and even sleep, I cut it off and intervene. But mild to moderate symptoms that is responding to conservative treatment, you have to wait for a minimum of 6 weeks. So patients who completed the 3 months time and the symptoms still there and not responding to conservative management, I cut it off and then put it through the surgical intervention. But in general, cervical radiculopathy, they do have a very good chance of improvement if you go with the conservative treatment.
Okay, I see. Thank you very much.
Welcome. سؤال ثاني؟ أعتقد إنه we're done and thank you for listening. وعندك شيء باقي يا رفاعي؟
يعطيك العافية دكتور. أتوقع كذا خلصنا إن شاء الله. تكون محاضرة مفيدة واستفاد الشباب. الحضور ما شاء الله كان جيد.
يلا بالتوفيق إن شاء الله.
شكرا دكتور.
في أمان الله جميعا. مع السلامة.